Imagine walking into a patient's room. You're ready to provide care, but unbeknownst to you, there's this invisible battle happening, a microscopic war waged by pathogens. How prepared are you really as a nursing professional to understand and, intervene in that battle? Welcome to the deep dive. Today, we're diving headfirst into the complex world of infections, healthcare-associated infections, HAIs, and specific conditions like COVID-19 and HIV.
That's right.
Our mission for this deep dive, we're taking a big chapter from your Lewis's medical surgical nursing text, and we're going to distill the most crucial information. We'll guide you step by step through the pathophysiology, risk factors, clinical signs, tests, and really importantly, the vital nursing management.
Think of it as your essential guide, your shortcut maybe, to confidently tackling these infection challenges in practice.
Exactly. Focusing on that core nursing process, the critical thinking you absolutely need for the NCLEX, and just, well, being a great nurse.
Right. So let's equip you with that high-yield knowledge. Where should we start? Maybe the absolute fundamentals. What is an infection? How does it spread?
Okay, yeah, let's unpack that.
Yeah.
At its core, an infection happens when a pathogen that's a microorganism that can cause disease invades your body.
It gets in, multiplies.
And then causes harm, the symptoms you see. They're often the result of what that pathogen is doing, plus our own body's inflammatory and immune responses kicking in.
And we tend to categorize these invasions by how far they reach, right? So a localized infection, just what it sounds like.
Limited, like a small spot, a skin wound maybe.
Exactly, confined to a small area. Now, if it starts spreading beyond that initial site, maybe to other nearby areas, that's disseminated. It's moving, but not, everywhere.
Okay, so disseminated is spreading, but not body-wide, which means if it does spread extensively, maybe through the bloodstream, that's when it's systemic.
Precisely. Systemic infection. That's often where the danger really ramps up, a major clinical concern.
Yep.
And to really understand these threats, we also need some basics of epidemiology.
Right, the study of how diseases spread and what causes them.
Yeah. And for you as nurses, two key terms you'll hear constantly are incidence and prevalence. They sound similar, but they're different.
Okay, can you break that down for us? Maybe use an example.
Sure. Let's take HIV in the United States. Incidence is the number of new cases diagnosed in a specific time, usually a year.
Okay, new cases.
So maybe around 36,400 new HIV cases each year. That's incidence. Prevalence, on the other hand, is the total number of people living with that condition at a specific point in time.
Ah, okay. So the total pool of people.
Right. For HIV in the U.S., that's about 1.2 million people currently living with it. Incidence is the flow, prevalence is the pool.
That's a really helpful distinction. And related to that, we hear terms like endemic, epidemic, pandemic. They describe different scales, don't they?
They really do. An endemic disease is kind of the expected baseline level of something that's just always present in a particular area. It's just there.
Like the background noise of disease?
Kind of, yeah. Then an epidemic is when you see a noticeable rise, an increase above that expected level in a community or region.
Like that open cough outbreak example.
Exactly. And then when an epidemic spreads really widely, geographically speaking, affecting whole countries or, a whole world, that's a pandemic.
And COVID-19 in 2020 is the example none of us will forget.
A very stark reminder, yes.
So, okay, if epidemiology maps the battlefield, who are the actual fighters? Let's zoom in on the pathogens. Bacteria, viruses, fungi, protozoa, prions. Quite a diverse group. Let's start with bacteria.
Okay, bacteria. Think of them as tiny saboteurs. They basically have two main ways to cause disease.
Okay.
They either sneak inside our human cells like the TB bacteria do,
Yeah.
or they stay outside but launch attacks like secreting toxins that damage cells. Staphylococcus aureus is a good example of that.
Knowing that difference must matter for treatment, right?
Absolutely. And nurses should also know bacteria are often classified by shape, like cocci are round, bacilli are rods. It helps with initial ID.
Interesting. Viruses, though, totally different, aren't they? Not even really cells.
Much simpler structures, yeah. Basically just genetic material, RNA or DNA, wrapped in a protein coat. They're obligate intracellular parasites.
Meaning they have to get inside a living cell to reproduce?
Exactly. They hijack the host cell's machinery. Think influenza, herpes viruses, coronaviruses, all common examples you'll encounter.
And then fungi. We often think athlete's foot, maybe thrush, but they can be worse.
They can be. While many fungal infections are localized, like tinea pedis, that's athlete's foot, the real danger often lies with immunocompromised patients.
Oh, okay.
In those individuals, systemic fungal infections can be incredibly dangerous, life-threatening even.
Hmm.
And even something usually harmless like Candida albicans, which is part of our normal flora, can overgrow and cause problems like thrush, especially if antibiotics wipe out competing bacteria.
Right, I've definitely seen that. Okay, what about protozoa and prions? They sound a bit more unusual.
Protozoa are single-celled, kind of animal-like microorganisms. They
Mhm.
cause things like amoebic dysentery, giardiasis, malaria,
Oh,
caused by Plasmodium.
oui.
Then you have prions. These are really unique. They're infectious particles, basically abnormally shaped proteins. No genetic material, which is wild.
Wow. So how do they cause disease?
They tend to affect the nervous system, causing these rare but devastating conditions called transmissible spongiform encephalopathies or TSEs. Creutzfeldt-Jakob disease is the most known example.
Okay, that covers the basic players. Now, let's shift to the threats that are, well, evolving. This landscape is constantly changing, right? We have emerging infections.
Exactly. Emerging infections are those that have recently popped up, increased in incidence, or seem like they're about to. Their origins can be all over the place.
Like what?
Sometimes unknown, sometimes they jump from animals to humans. It's called zoonosis. Or there could be known diseases that just change somehow. Bioterrorism is another potential source, unfortunately.
Any key examples nurses should have on their radar?
Oh, definitely. Think Ebola, that severe hemorrhagic fever, West Nile virus carried by mosquitoes, various influenza variants like H1N1 swine flu or H5N1 avian flu, both
Or
zoonotic.
jumping from animals?
Right. And of course, the coronaviruses, especially SARS-CoV-2, causing COVID-19. A massive global example of an emerging respiratory threat.
And it's not just new stuff appearing, but also re-emerging infections, right? Things we thought were under control.
That's a really critical point for you to understand. Diseases we had controlled can definitely resurface.
Why does that happen?
Several factors play a role. Increased population density, sometimes inadequate sanitation, misuse of antibiotics certainly doesn't help.
Hmm.
Bioterrorism is a risk, and a really big one. Falling vaccination rates. We've seen measles, diphtheria, pertussis have comebacks because vaccination levels dropped in some communities.
And travel makes it hard to truly eradicate things globally.
Absolutely.
Mm.
A disease might be gone from one country, but international travel means it can be reintroduced easily.
Okay, this next one feels particularly worrying for healthcare. Antimicrobial resistant infections, the superbugs.
It's a huge global health crisis. These pathogens are constantly evolving, figuring out ways to resist the drugs we rely on.
How do they do that? Is it just random mutations?
It can be genetic changes, like mutations or acquiring new DNA, yeah, but also biochemical defenses. They might develop enzymes that literally destroy the drug, or they alter the target site the drug normally attacks.
Can you give us a couple of the big ones nurses absolutely need to know?
For sure, MRSA, methicillin-resistant staph aureus. It started mostly in hospitals, HAMRSA, but now we see CAMRSA, community-acquired, and that one can be nastier, causing really rapid skin infections or even systemic disease.
Wow.
Then there's VRE, vancomycin-resistant enterococci. These are tough bugs, really virulent, and they can survive on surfaces like bed rails or tables for weeks.
Weeks. That's scary.
It highlights the need for meticulous cleaning, and we also see resistance in others, like Klebsiella pneumoniae, resisting powerful carbapenem antibiotics.
So who's to blame for this resistance? Is it just bad luck with evolution?
Well, evolution plays its part, but unfortunately we humans contribute significantly,
Yeah.
both healthcare professionals and patients.
How so?
HCPs might prescribe antibiotics when they aren't needed, like for a virus, or maybe feel pressured by patients to give something. Using inadequate regimens or overly broad-spectrum drugs also drives resistance.
And patients.
Patients contribute when they skip doses or don't finish the entire prescription course because they feel better or, saving leftover antibiotics for next time.
Using old meds.
Yeah. That's why patient education from nurses is so critical. And remember, it's not just bacteria. Viruses, fungi, parasites, they can all develop resistance. That's why we often use the broader term antimicrobial resistance.
That makes sense. Okay, staying within the healthcare setting, let's talk specifically about healthcare-associated infections, HAIs, infections people actually get while receiving care. How big a problem is this?
It's significant. We're talking around 722,000 HAIs each year in the U.S. alone. That means about 1 in every 25 hospitalized patients picks up an infection they didn't come in with.
1 in 25. That's a lot.
It is, but here's the key thing for you as a nurse to remember. Experts estimate about 1/3 of these HAIs are preventable.
Preventable. Okay, that puts the responsibility squarely on us. How are they usually transmitted?
Most commonly, unfortunately, by healthcare professionals through direct contact. Hands are major carriers.
Are we getting any better at preventing them?
Yes, thankfully. there's been real progress. Due to better infection control practices, things nurses do every day, we've seen decreases in major HAIs, like CLAB-SIs,
Central line infections.
right, and CIUDIs, catheter-associated UTIs, also surgical site infections, SSIs, C. diff infections, and MRSA bloodstream infections.
That's good news, but still a challenge.
Absolutely. High-risk patients, like those undergoing surgery or who are immunocompromised, are still very vulnerable. And common bacteria like E. coli and S. aureus are still frequent culprits. Vigilance is key.
Which leads us perfectly into the nurse's shield, prevention and management. This is where you, the nurse, truly make a difference. You play such a key role. So let's start with assessment. What risk factors should you be looking for in patients?
When you're assessing your patient, you need to actively look for factors that increase their infection risk. Think about their age very young, and older adults are more vulnerable. Are they immunized? Do they have underlying conditions like diabetes or anything impairing their immune function?
Okay.
Do they have indwelling devices like urinary catheters or IV lines? Have they had recent surgery? All these things significantly raise the risk.
So once you identify someone at risk, what are the absolutely crucial nursing actions for prevention? The non-negotiables.
Top of the list always.
Yeah.
Meticulous hand hygiene. That means proper hand washing with soap and water, or using an alcohol-based hand sanitizer correctly and frequently.
Before and after patient contact, between tasks.
Absolutely. An appropriate use of PPE, personal protective equipment, gloves, gowns, masks, eye protection, depending on the situation. Critically, you need to change gloves and wash your hands between tasks, even if you're working with the same patient.
That prevents moving germs from one body site to another.
Exactly. Also, proper cleaning of reusable equipment is vital, trying to avoid or limit invasive procedures whenever possible. Using strict aseptic technique when you do perform procedures like catheter insertion or wound care, and implementing specific care bundles.
Ah, those bundles for things like CIUTI or CLAB-SI prevention.
Yes, those evidence-based sets of practices that, when used together, significantly reduce infection rates. Following those bundles is a key nursing responsibility.
Okay, and within prevention, we have specific infection precautions. What guidelines do nurses follow there?
The CDC provides a two-tiered approach. The first level is standard precautions.
And those apply to
Everyone, all patients, all the time, regardless of their diagnosis or presumed infection status. Standard precautions cover potential contact with blood, all body fluids except sweat, secretions, excretions, non-intact skin, and mucous membranes.
So basically, assume everyone could potentially transmit something?
Pretty much.
Yeah.
It includes hand hygiene and using appropriate PPE based on the task you're performing.
Yeah.
Then the second level is transmission-based precautions.
And these are in addition to standard precautions?
Yes, always in addition. They're used for specific pathogens that are known to be highly transmissible via certain routes.
Can you quickly run through the three types?
Sure, there's airborne precautions. These are for tiny organisms that can travel long distances on air currents, like TB or measles. Think negative pressure isolation rooms and N95 respirators.
Okay.
Then droplet precautions. For larger droplets that travel short distances, usually generated by coughing, sneezing, talking. Influenza, bacterial meningitis are examples. Requires a regular surgical mask for staff within close proximity.
Got it. And the last one?
Contact precautions. For germs spread by direct patient contact or contact with contaminated items in their environment. MRSA, VRE, C. difficile fall into this category. Requires gloves and gowns for patient care.
And your job as the nurse is knowing which precautions are needed for which patient and following them consistently?
Absolutely critical.
Okay, let's talk about antimicrobial therapies. Before you even give that first dose of an antibiotic, what are some critical nursing steps?
Oh, several key things. First, always get a thorough history of allergies. Penicillin allergies are common and can be serious.
Right.
Second, and this is huge, collect any necessary cultures, blood, urine, sputum, wound, before starting the antibiotic.
Why before?
Because the antibiotic can start killing the bacteria immediately, and if you culture after it's started, you might not grow the organism or get accurate sensitivity results. You need to know what you're treating before you treat it, if possible.
Makes sense.
What else? Get baseline assessments, especially things like kidney and liver function, as many antibiotics are cleared or metabolized by those organs. Set up scheduled around-the-clock dosing, not just PRN, to maintain consistent, effective drug levels in the blood. And always be thinking about potential drug interactions, even with over-the-counter stuff like antacids.
Okay, and with antibiotics themselves, there's bactericidal versus bacteriostatic.
Right. Bactericidal antibiotics kill the bacteria directly. Bacteriostatic ones inhibit their growth or reproduction, basically slowing them down so the patient's own immune system can clear the infection.
And different classes have different risks, right? Like you mentioned penicillin allergies.
Exactly. Vancomycin, for instance, carries risks of kidney damage and hearing loss, nephrotoxicity, and ototoxicity. Fluoroquinolones can cause photosensitivity or even tendinitis. As a nurse, you need to know the key risks for the drugs you're giving and monitor for them.
Beyond just giving the meds, patient and caregiver teaching seems like maybe the most important nursing role in fighting resistance.
It absolutely is. This is where you build that shield for the future. You have to hammer home these points.
Yeah.
Only take antibiotics prescribed for you.
Don't share.
Never share. Wash your hands frequently.
Mm.
Follow the directions exactly. Finish the entire course, even if you feel better. Don't skip doses.
Yeah, stopping early is a big problem.
Huge. And don't demand antibiotics for things like colds or the flu, which are viral.
Yeah.
And never, ever take leftover antibiotics from a previous illness. These actions directly fuel the development of resistant bugs. You are the key educator here.
Definitely. Okay, one last point on general infection principles. Gerontologic considerations. Infections in older adults, they present differently sometimes?
They really do. First, older adults have significantly higher rates of HAIs, maybe 2 to 3 times higher, especially in long-term care settings.
Why is that?
Partly due to age-related decline in immune function called immunosenescence. Plus, they often have more chronic comorbidities like diabetes that increase risk. Common infections are things like pneumonia, UTIs, skin infections, TB. But here's the crucial nursing insight, the thing you really need to watch for. Infections often present atypically in older adults.
What does that mean? Not the usual signs.
Exactly. Don't just rely on looking for a fever. Fever might be absent or blunted. Instead, you need to suspect infection if you see subtle changes in cognition confusion, agitation, or changes in behavior, or even just a decline in their ability to perform their usual daily activities.
So a change from their baseline function could be the first sign.
Often, yes. That's a classic critical thinking point for nurses caring for older adults.
Excellent point. Okay, let's shift gears now and apply some of this to our first specific case study, COVID-19, something that profoundly impacted all of us.
Indeed. The pandemic really brought infectious disease to the forefront. What stood out was its rapid spread, often through respiratory droplets, its surprisingly long incubation period, up to 14 days, and that tricky asymptomatic transmission.
People spreading it without even knowing they were sick.
Exactly. A huge challenge for control.
So pathologically, how does the virus SARS-CoV-2 actually cause disease? What's happening inside the body that nurses should grasp?
Okay, so SARS-CoV-2 is an RNA virus. It has those characteristic spike proteins on its surface. These spikes are the key they bind to specific receptors on our cells called ACE2 receptors.
Where are those receptors found?
Primarily in the upper respiratory tract, which explains the respiratory symptoms, but also other places like the eyes, the GI tract, as binding lets the virus enter the cell. Then it triggers immune responses. Cytokines get released, there's cellular disruption. In mild cases, the body handles it. But in severe cases, you can get this massive inflammatory cascade, sometimes called a cytokine storm.
And that leads to the really bad outcomes.
Yes, potentially leading to ARD, acute respiratory distress syndrome, where the lungs fill with fluid and fail, and even MODS, multi-organ dysfunction syndrome, where other organs like kidneys or heart start to fail too.
The clinical picture was so incredibly varied, wasn't it? From no symptoms to critical illness.
Absolutely, a huge spectrum. Common symptoms nurses were looking for included cough, shortness of breath, dyspnea, fatigue, fever, headache, muscle aches.
And that unique loss of taste or smell?
Right, anosmia or agysia,
Yeah.
a very specific clue sometimes. But it wasn't just respiratory. We saw widespread systemic effects, cardiac issues like myocarditis, neurological problems, kidney and liver injury, GI symptoms. As a nurse, you had to think multi-system.
Who was most at risk for getting severely ill? Who did nurses need to watch most closely?
The big risk factors were older age, generally defined as 65 and older, and having certain pre-existing conditions.
Right.
Things like cancer, diabetes, chronic kidney disease, heart conditions, obesity, even smoking history. These significantly increase the risk of severe disease, hospitalization, and death.
How was it diagnosed, and what was the core nursing management?
The gold standard diagnostic test was the RT-PCR test, usually from a nasal or throat swab, looking for the virus's genetic material. Nursing management really depended on severity.
For mild cases at home.
Focus was on teaching strict quarantine or isolation, meticulous hand washing, supportive care like rest and fluids, and really clear instructions on when to seek medical attention if symptoms worsened.
And for hospitalized patients?
Strict isolation, usually airborne and contact precautions early on.
Ah,
Close monitoring of respiratory status, oxygen saturation, work of breathing, and hemodynamics, being ready to rapidly escalate care if they declined. Plus, managing symptoms like fever with acetaminophen.
what about treatments and vaccines? They evolved quickly.
They did. Treatments included things like monoclonal antibodies that mimic our own immune response, and antiviral agents like remdesivir. Vaccines were the true game changer, though.
Can you briefly explain the main vaccine types? Crucial for patient education.
Sure. The two main ones initially were mRNA vaccines and viral vector vaccines. The mRNA vaccines, like Pfizer and Moderna, basically give your cells instructions to make a harmless piece of the spike protein. Your immune system then learns to recognize and fight it. Importantly, they don't contain live virus and don't alter your DNA. The viral vector vaccines, like Johnson & Johnson, use a different harmless virus, like an adenovirus, to deliver the genetic instructions for that same spike protein. Again, teaches the immune system without causing disease or changing host DNA. Nurses played a massive role in educating patients about how they work and managing expectations about common side effects like sore arms or fatigue.
That education piece was huge. Okay, let's move to our second case study. HIV, human immunodeficiency virus, a retrovirus causing immunosuppression, but now often a manageable chronic condition. What's the single most important concept about HIV today that you, as a nurse, need to understand and communicate?
Without a doubt, it's UU, undetectable equals untransmittable.
You break that down.
It means that a person living with HIV who's on effective antiretroviral therapy, or ART,
Yeah.
and achieves and maintains an undetectable viral load, meaning the amount of virus in their blood is so low it can't be measured by standard tests, cannot sexually transmit HIV to their partner.
Cannot transmit sexually. That's huge.
It's revolutionary. It drastically reduces stigma, empowers patients, improves quality of life, and is a cornerstone of public health prevention efforts. Every nurse needs to know this and share it accurately.
Absolutely vital. So reminding ourselves, how is HIV transmitted? And just as importantly, how is it not transmitted? Addressing those fears.
Okay, transmission occurs primarily through contact with specific infected body fluids. Blood, semen, preseminal fluid, rectal fluids, vaginal secretions, or breast milk.
And not through.
HIV is not spread through saliva, tears, sweat, urine, feces, emesis, sputum, or respiratory droplets. It's also not spread by casual contact hugging, dry kissing, sharing utensils, toilet seats, mosquitoes.
Yeah.
Debunking these myths is critical nursing work to fight stigma.
What about the main modes?
Sexual transmission is the most common route globally, especially unprotected anal or vaginal sex. Risk is higher if the person with HIV has a high viral load or if there's trauma or other STIs present. Contact with blood, mainly through sharing needles or other injection equipment for drug use. Blood supply safety is now very high due to screening, but sharing needles remains a major risk. For healthcare workers, needle stick risk is low, about 1.3%, but real.
And mother to child.
Yes, perinatal transmission can happen during pregnancy, labor, delivery, or breastfeeding. But here's the amazing part. If the mother is on effective RT, the risk of transmission drops from about 25% down to less than 1%. Treatment is prevention.
Incredible progress. Let's look at the pathophysiology. How does HIV actually attack the immune system? Those CD4 cells.
Right. HIV is a retrovirus, an RNA virus. It primarily targets CD4 plus T cells, often called helper T cells, which are absolutely crucial commanders of our immune response.
How does it get in and destroy them?
It uses its own surface proteins to bind to receptors on the CD4 cell, mainly the CD4 receptor itself, and a coreceptor. This allows it to fuse with the cell membrane and inject its RNA. Then a key enzyme called reverse transcriptase converts the viral RNA into DNA.
Making a DNA copy from RNA, that's why it's a retrovirus.
Exactly. Then another enzyme, integrase, inserts this viral DNA into the host cell's own DNA in the nucleus. Now the cell is permanently infected, and every time it divides, it copies the viral DNA too.
Wow, it integrates right into our genome.
It does. Later, the viral DNA is used to make new viral RNA and proteins. Another enzyme, protease, cuts these long protein strands into smaller pieces to assemble new virus particles. These new viruses then bud off from the cell, often destroying it in the process, and go on to infect other CD4 cells.
Leading to that drop in CD4 count?
Precisely. A healthy immune system usually has a CD4 count above 500 cells per microliter. Immune problems start creeping in below 500. Below 200, the immune system is severely damaged, and the person becomes highly susceptible to opportunistic infections and cancers.
And those opportunistic diseases are the main cause of illness and death, not HIV directly.
Largely, yes. It's the infections and cancers that take hold when the immune system is weak that cause the most severe problems.
What does a clinical progression look like for a nurse? What are the stages?
It typically follows a pattern, though it varies. About 2 to 4 weeks after infection, many people develop an acute infection stage. Symptoms are often like mono or a bad flu fever, swollen lymph nodes, sore throat, fatigue, maybe a rash.
Okay, sounds nonspecific.
It is, which is why it's often missed. But here's the crucial part for transmission. During this acute stage, the viral load, the amount of virus in the blood, is extremely high. People are most infectious then, even if they don't know they have HIV.
Good point. Then what?
It usually progresses to chronic HIV infection. This phase can be broken down further. First, there's often a long asymptomatic period. Without treatment, this can last an average of 10 years. The virus is still active and replicating, damaging the immune system slowly, but the person feels relatively well. They can still transmit HIV during this time.
So they might not know they have it for years.
Exactly. Then, as the CD4 count continues to drop and viral load rises, they enter the symptomatic infection stage. Now symptoms become more persistent or severe chronic diarrhea, drenching night sweats, persistent fevers, severe fatigue, weight loss. This is also when you start seeing characteristic opportunistic conditions more often, like oral thrush, shingles outbreaks, Kaposi sarcoma lesions, or oral hairy leukoplakia.
And eventually it can progress to AIDS. What defines that stage?
AIDS-acquired immunodeficiency syndrome isn't a separate disease. It's the most advanced stage of HIV infection. It's diagnosed based on specific CDC criteria. Either the CD4 count drops below 200 celsius.
Okay, that number 200 is key.
It is. Or the person develops one or more specific serious opportunistic infections like pneumocystis pneumonia or invasive cervical cancer or CMV retinitis, or certain opportunistic cancers like Kaposi sarcoma or Burkitt's lymphoma, or wasting syndrome, significant involuntary weight loss. Meeting any of those criteria in the presence of HIV means an AIDS diagnosis.
So how do we diagnose HIV and how do nurses monitor it?
Diagnosis is usually done with tests that detect HIV antibodies and/or antigens in blood, or sometimes saliva. Combination tests that look for both are common now and can detect infection earlier. Nurses need to understand the window period, though.
The time after infection, but before the test turns positive.
Right. It takes time for the body to produce detectable antibodies or antigens, usually about 3 weeks for the newest tests. So a negative test right after a potential exposure might need repeating later.
And for monitoring someone living with HIV.
2 key lab tests nurses track closely. The CD4 cell count tells us about the current state of their immune function. Higher is better. And the viral load, which measures how much HIV is actively circulating. The goal of treatment is to get the viral load to undetectable.
Which, as we said, means you leave for sexual transmission, but not cured.
Exactly. Undetectable doesn't mean cured. The virus is still present in reservoirs in the body, but it means the treatment is working very well, the immune system can recover, and sexual transmission risk is eliminated. Nurses also monitor for other things like anemia, low white counts, liver function, and screen for co-infections like hepatitis B or C.
Since HIV isn't currently curable, what are the main goals of care? What are nurses and the interprofessional team aiming for?
The goals are really focused on managing it as a chronic condition. So, monitoring the disease progression and immune status, initiating and monitoring antiretroviral therapy, preventing and treating any opportunistic diseases that arise, managing symptoms to maintain quality of life, preventing complications of the disease or treatment, and critically, preventing further transmission of HIV.
RT is the foundation of treatment. What are the goals of ART, and why is adherence so non-negotiable?
ART involves using a combination of drugs, usually 3 or more from different classes, that attack the virus at different points in its replication cycle. This combination approach is key to preventing resistance. The main goals are to suppress the viral load as low as possible, ideally to undetectable levels, increase and maintain the CD4 count, prevent HIV symptoms and opportunistic illnesses, delay disease progression, and prevent transmission.
And adherence.
It is absolutely, positively crucial.
Yeah.
HIV replicates incredibly fast, and if drug levels drop, even briefly because doses are missed, the virus can quickly mutate and develop resistance to those drugs. Once resistance develops, those drugs may no longer work for that patient. Consistent, lifelong adherence is essential for the treatment to work and to preserve future treatment options.
That's a huge teaching point for nurses.
Massive. Nurses spend a lot of time discussing adherence strategies, simplifying regimens like using single-tablet regimens, and managing side effects to help patients stick with it. We also teach about potential drug interactions, including with over-the-counter meds or herbal supplements.
When you're doing your nursing assessment for someone potentially at risk or newly diagnosed, it starts with risk behaviors,
Mhm.
but that can be sensitive, right? Ethical considerations.
Definitely. Your assessment has to cover sensitive topics: sexual history, drug use history, past blood transfusions, especially before 1985 when screening began, potential contacts. You need to do this non-judgmentally, creating a safe space. And yes, there are ethical and legal aspects around confidentiality versus, in some cases, partner notification or public health reporting requirements, which vary by location.
Right.
Beyond risk factors, a thorough head-to-toe physical assessment is needed to establish a baseline and look for any current signs or symptoms: swollen lymph nodes, skin rashes, or lesions like Kaposi sarcoma, oral thrush, unexplained weight loss, neurological changes. A good psychosocial assessment is also vital: coping, support system, mental health.
What about health promotion and prevention? What strategies do nurses teach?
We use a combination approach. Biomedical prevention includes things like pre-exposure prophylaxis.
That's for HIV negative people.
Right. Taking a daily HIV medication significantly reduces the risk of getting HIV through sex or injection drug use. It's highly effective when taken consistently. There's also NPAP, non-occupational post-exposure prophylaxis. That's taking RT after a potential exposure, starting within 72 hours for 28 days.
Okay, PAP before, NPP after potential exposure.
Exactly. Then there's behavior modification, teaching safer sex practices, abstinence, limiting partners, and consistent, correct use of barriers like condoms or dental dams. For people who inject drugs, it's about harm reduction, never sharing needles or equipment, accessing sterile needles through exchange programs where available.
And advocating for testing.
Hugely important. Advocating for universal, voluntary HIV testing as a routine part of medical care helps normalize it, reduces stigma, identifies people who don't know they have HIV so they can get care, and ultimately prevents new infections.
Once someone is diagnosed and on treatment, what are some key nursing strategies for improving ART adherence and helping them know when to report symptoms?
Improving adherence involves a lot of patient education and support, making sure they understand why it's so important. Reviewing the specific regimen, potential side effects, and reassuring them that side effects can often be managed or the regimen changed if needed.
Practical tips.
Using memory aids, tapes, pill boxes, phone alarms, calendars, linking medication taking to daily routines, simplifying the regimen as much as possible, involving trusted family or friends for support if the patient agrees, using a multidisciplinary team approach.
And knowing which symptoms are urgent.
Yes, teaching them which symptoms need immediate attention, like any change in level of consciousness, severe headache with nausea, vomiting, vision changes, persistent shortness of breath, versus those that could be reported within 24 hours, like a new rash or fever. Clear guidance is key. And always reinforcing that undetectable equals untransmittable for sex, but doesn't mean cured.
Let's touch quickly on gerontologic considerations for HIV. We mentioned older adults getting infections more often, but what about HIV specifically?
The population of older adults living with HIV is growing significantly, partly because RT is so effective. People are living much longer lives.
Which is great news.
It is. But nurses need to be aware that older adults with HIV may develop age-related chronic diseases: heart disease, diabetes, certain cancers, osteoporosis, at an earlier age than their HIV-negative peers. Managing these comorbidities alongside HIV is complex.
Polypharmacy must be a big issue too.
Huge. Managing potential drug interactions between RT and medications for other conditions is a major challenge. And unfortunately, stigma can still be a significant barrier for older adults, impacting their willingness to seek testing, disclose their status, or access care and support.
So quite a few unique challenges there.
Definitely.
Okay, let's wrap up. Today we've really taken a deep dive, haven't we, into this complex world of infections. We started with the basics: epidemiology, pathogens. Then we looked at the critical threats, emerging, re-emerging, and those scary resistant strains.
We explored your absolutely indispensable role as a nurse in prevention and management, covering everything from assessment and hand hygiene to specific precautions and antimicrobial stewardship.
And we applied it all through the lens of COVID-19 and HIV, looking at their pathophysiology, how they present, how we diagnose and manage them, emphasizing those key nursing priorities like monitoring, patient education, and adherence.
We hit on core concepts like standard versus transmission-based precautions, bactericidal versus bacteriostatic, the vital importance of finishing antibiotics, recognizing atypical presentations in older adults, the multi-system nature of COVID, and the powerful UU message in HIV. This knowledge really is your shield in practice.
It empowers you to navigate this ever-shifting landscape. Which brings us to our final thought for you, the listener. As you continue your journey in nursing, remember that infectious diseases are constantly changing. New pathogens emerge, old ones resurface, resistance keeps evolving. So, thinking about all this, what do you believe is the single most important quality a nurse must cultivate to remain truly effective day in and day out in the face of these ever-changing, often invisible threats? Something to think about.